Good evening, everybody. I'm very happy that you've come out today. I know it's end of August and it's a Friday, but we were determined to do this event regardless for two reasons. One, because we'd scheduled it a few months back and had to reschedule it to today, and also because we knew we were going to record it anyway for more global reach, let me put it that way, later. So, as Susanna already mentioned to you, this topic has really occupied and challenged me for best part of now 15 years. And I've always had a special interest in cancer and what we might be able to do about it from less invasively. And because of my philosophy and ethos, which is to find more natural, less invasive solutions for problems, when I came across and I'll talk about it in more detail tonight, when I came across breast thermography, I realized that there was a really valuable tool here, not just for breast cancer detection and detecting it earlier, but also for breast health preservation. Now, it'll become clear to you as I explain why there's a distinction between what this does and what is achieved with mammography. And by the end of the evening, I think that will be crystal clear in your minds. And if it isn't, you can ask a question at the end about it. All right, so changing breast cancer risk. Why and how must we change the status quo? Now, I chose those words very carefully. They're very weighted to what I'm talking about this evening. So I believe that we can change breast cancer risk, and we can do it now. It's just that conventional medicine is not on this page yet. One of my missions is to help them to get on this page, as I speak as a medically trained doctor, of course. So, let me just point out, by the way, the laser doesn't work on these slides, so I'm going to have to use the old-fashioned pointer. Okay? This is a breast thermogram, and I'm going to show you a lot more of them. This is a woman that had breast cancer. Now, I just want you to, on this opening slide, you see the difference in her left breast compared to her right. You notice that there is a lot more dark areas, and if this was a color map, it would show as red. So there's a lot more heat and a lot more vascular patterning on the side that she has a breast cancer. I'll show you a lot more examples on that, but that's just to plant a seed in your mind for some things I'm going to say later. So, let's start with some statistics and background information. About 40,000 new cases of breast cancer in the UK every year. The lifetime risk now of women in the UK is about 1 in 9. And in the US, it's about 1 in 8. That's lifetime risk. There are about 11,500 deaths a day. Now, that was 2002. 11,000, that's in the year. 33 deaths from breast cancer every day in the UK. Just think about that for a minute. Every day, 33 women die from breast cancer. It's really sobering, isn't it? That's just in the UK. It's the commonest cancer in women in the UK, of course. The highest incidence you find in North America, 8 times the amount that you find in China. So there are definitely regional differences in incidence for reasons that we'll touch on a little bit later. And some, we don't fully understand that, by the way, but some of those reasons I'll touch on. It's estimated that you have double the treatment success if you detected the cancer when it's localized rather than obviously when it's spread. Yeah, in fact, twice, we said that, double the treatment success. And 30% of breast cancers occur in women less than 50. Now, as you know, in the UK, women are called for mammography at age 50. And yet, a third of breast cancers occur in women before they reach that age. Now, I just put this up because I want to show you where the UK sits in comparison to the rest of Europe. And you can see more or less, with the possible exception of Belgium, which has higher mortality for reasons I don't know. But in Europe generally, it's about the same. We can compare UK to the rest of Europe in terms of incidence of breast cancer. Whereas if you look down at the bottom here, this is all mainly Europe anyway. But the point I wanted to get is that the incidence is about the same, largely in Europe. Now, if you look across the globe, you see some quite categorical differences. So here we have USA, here's UK. But if you look down here at China and Japan, look how the incidences change. Okay? Mortality is the darker colours. So it's just to contrast where we sit here compared to the rest of the world. All right, so the status quo is early detection. We want to detect breast cancer as soon as possible. The motivation behind mammography screening is to try and detect breast cancer as soon as possible. However, I'm going to show you that mammography is not early detection. I'll show you why. So, in fact, let's go into that. It was brought in as a screening tool in 1962. So not that long ago, really. Premise is early detection of breast cancer. That's why women called at age 50, they don't necessarily have a problem, but they're screened to see if they do have a problem. It's a test of anatomy, a test of structure, which means you have to have something big enough to block enough X-rays before you can see it on a mammogram. That's how it works. If it's too small to block enough X-rays, you don't see it. I would argue just on that basis, it's late-stage detection. Now let's explore that a bit further. Right, so before we do that, early detection. These are some of the criteria that should fit any tool that's used for early detection. First of all, it should have high sensitivity for small cancers. It should be cost-effective, and it should be safe and acceptable to the population being screened. Okay? 3 characteristics of an effective screening tool. So I want you to put mammography and what I'm going to say about thermography into those contexts. Okay? So, just out of interest, if you're trying to palpate your breast to feel a tumour, usually you can't feel anything that's less than 2 centimetres. So it's a very blunt tool, and doctors are now not so avidly recommending that anymore. And one of the reasons for that is it leads to, a lot of women have lumpy breasts anyway. It leads to women getting concerned about what are largely benign lumps, which occur in a large proportion of women. MRI scanning can detect at about 1.3 centimetres. If you combine MRI with mammography, okay, we can get it down to 1.1 centimetre. So what I want you to get from this slide is that the detection size for the current structural screening, i.e. mammography and even MRI, doesn't get less than about 1 centimetre in size. If it's less than that, you're not going to reliably detect it. And this is a schematic. There's an error on this, which I'll explain in a minute. This is a schematic showing the evolution, development of breast cancer. Now, from what we've just said, mammography, MRI, ultrasound's even blunter as a tool, and is not good for screening generally. You're going to detect at about 1 centimetre. This slide also shows when the tumour starts to metastasize and break free from the local area. But actually, this is incorrect. We now believe that this can start to occur from 5 years after a cancer cell first forms. So in other words, we have to come back here. Bear in mind, I'm about to tell you that it usually takes 6 to 10 years to reach 1 centimetre in size. And I just told you that the science now shows that it can take just 5 years before metastases start to form. So really, these should be drawn further back here. Really, what we want to aim for is detection down here, rather than here. So, it takes about 10 years, as I've just said, for a tumour to grow to 1 centimetre in size. At that point, it's approximately 1 billion cancer cells. Or rather, it's about 500 million cancer cells, actually, in 1 centimetre of size. And obviously, it depends on how rapidly the cancer cells are dividing. So the consensus is somewhere between 3 to 10 years to reach 1 centimeter in size, depending on the rate of growth. The number of blood vessels supplying a tumor is proportional to the likelihood that it will spread. It takes 5 years, as I've just said to you, 5 years from a cell becoming malignant to the time it can metastasize. And here's a very sobering thought. This comes from research data on wide resection of what we thought were local tumors. That means on the scan it looked like a single area. And the surgeon has taken 4 centimeters of tissue around what was thought to be a single tumor. 2/3 of those wide excisions actually show microdeposits in the surrounding 4 centimeter tissue. Did you follow that? That means that what we thought was local, in 2/3 of cases, is actually already spreading. So for all of these reasons thus far, you can see mammography can't truly be classified as an early detection tool. It has limitations. So it leads to no survival advantage. This is the other thing. It's late detection, as we've already said. 1/3 of mammograms give false positive readings, and a third false negative. It has low sensitivity in dense breast, and actually about half of women have dense breast tissue anyway. So you see the problem here. 75% of biopsies turn out to be negative. And normally we don't biopsy a tumor if it doesn't look, unless it's solid, and you can't tell from the scan whether it's something malign or benign. So we biopsy to make sure. But 75% of those turn out to be negative. Each mammogram increases a premenopausal woman's risk of cancer by 1%. So a woman who is premenopausal, and this is another reason it's not appropriate for young women, because their breasts are more sensitive to the ionizing radiation and actually are more likely to develop cancer from exposure to radiation. So it's not a great tool for young women because breasts are dense and the ionizing radiation causes more problems. There's reduced sensitivity of mammography in women who are on HRT and who have a family history of breast cancer, and those are 2 groups of women we especially should be vigilant over. 10% of patients with breast cancer will have a normal mammogram, and there are also some published concerns over compression of existing cancers at the time of mammography. Now, just as a thought provoker, it takes 22 pounds of pressure to rupture the capsule of a cancer, the outer capsule of a cancer. But the average pressure that a woman's breast is exposed to at mammography is about 42 pounds. So what if you have a small tumor that you haven't been able to feel and you're putting it under that pressure? You see, there's another potential problem. And this highlights this further. This was a study published in 2012 by Katrina Packman, based in Germany, and she does work with circulating tumor cells, circulating epithelial cells. And she reported in this paper that after mammography, guess what? You get an increase in these circulating epithelial cells. Evidence that the compression is releasing cells into the circulation. That's not good. Now, for those of you ladies who haven't experienced mammography, this is how it's done. So your breast is placed between 2 plates, and the breast is flattened, and the reason for that is to spread the tissue out so that when you expose it to the radiation, you can see more of the tissue. It makes sense, but this is not a non-painful procedure. And we've already highlighted the concerns over compression of the breast. 6 to 46% of women with invasive cancer will have a negative mammogram, especially if they are young, they have dense breasts, which most young women have anyway, or have mucinous lobular or rapidly growing cancers. So, even despite over and above what I've already told you about how it's missing, 6 to 46%, that's a broad range. Peter Gertsch He is he's a co-founder of the Cochrane Collaboration. He's the director of Nordic Cochrane Institute in Copenhagen. Very highly respected organization, which are behind a lot of reviews and publications of science. Highly respected. This is what he said in a paper. I think he published this in 2011. These are the summary points. He said this, and he's written a book on this, by the way. He said, screening with mammography does not reduce the occurrence of advanced cancers. Rigorous observational studies in Europe have failed to find an effect of mammography screening. Mammography screening produces patients with breast cancer from among healthy women and increases the number of mastectomies performed. The most effective method we have to reduce the occurrence of breast cancer is to stop screening. He also said, at the end of that paper, if screening had been a drug, it would have been withdrawn from the market. Thus, which country will be the first to stop mammographic screening? Now, these are very powerful statements that this guy, who is one of the heads of the Cochrane Institute, is making. And he makes them not just flippantly, but based on solid, reviewed research. Switzerland became the first country to step up and say, okay, based on all of the reviewed evidence, we can no longer justify offering mammography screening to women. Now, these are some of the points that came out of their paper, which was published, I think it was 2014, actually. They met for 1 year, a group of, as it says here, a group of experts, a medical ethicist, a clinical epidemiologist, a pharmacologist, oncology surgeon, a nurse scientist, a lawyer, and health economist. And it took them a year to review all of the published data on mammography. And what they concluded was the evidence simply did not back up the global consensus of other experts in the field, notice that, suggesting that mammograms were safe and capable of saving lives. They also said, it echoes growing sentiments around the globe that mammography for breast cancer screening in asymptomatic populations no longer makes sense. Now, there were 3 points that they brought out in their arguments further. First of all, they said the people who are currently stating that it does save lives and it does have merit, that data is largely based on outdated clinical trials. Based between, basically, the last trial was 1991. So they wanted, if you notice here, could the modest benefit of mammography screening in terms of breast cancer mortality that was shown in trials initiated between 1963 and 1991 still be detected if a trial was conducted today? Okay, so that's what they analyzed, and they found, when they looked at the data from modern day up to modern day research, it did not concur with the previous conclusions. The experts noted that they were struck by how non-obvious it was that the benefits of mammography screening outweighed the harms. This is very important. A recent study, and they highlighted this, published in the British Medical Journal, one of the largest, longest studies of mammography to date, which was around 90,000 women, followed for 25 years. This is a huge study. It found that mammograms have absolutely no impact on breast cancer mortality. Absolutely no impact. The Cochrane Collaboration, which I just mentioned to you, also published in 2013, and they said, there's no evidence that mammography screening has an effect on overall mortality, which taken together seriously questions or calls into question whether mammography screening really benefits women. And there was a third point that the Swiss group made. Women's perceptions of mammography benefits do not match reality. What they meant by that, and they discussed it, is that women are being made to feel irresponsible if they choose not to have a mammogram. But what they were saying is, based on all the evidence, they're not being irresponsible. They're expressing a desire based on what is current scientific evidence, which is there's no evidence that it actually helps to have one. Do you follow that? So the Swiss were upset about this. It was published in the New England Journal of Medicine, this paper, and it created chaos, as you can imagine, amongst the breast cancer fraternity. And there's still a lot of denial going on over the published science, by the way. So, now this is sobering as well, and I want to just take a minute over it because it's important. BMJ 2012 showed that women carrying BRCA1 or 2 mutation, which as you know increases risk of breast cancer if you carry this mutated gene, by between 60 and 80%. It's highly significant. Also increases the risk of ovarian cancer, 40 to 60%. These women who carry BRCA are particularly vulnerable to radiation-induced cancer. Women carrying this mutation who are exposed to diagnostic radiation, i.e. mammograms, before the age of 30 were twice as likely to develop breast cancer compared to those who did not have the mutated gene. Now, even though that's been published, look at the next paragraph. Despite these findings, the National Cancer Institute reports that some expert groups recommend women with BRCA1/2 mutation have a mammogram every year starting as young as the age of 25. I had a patient this week came in, BRCA positive, 28-year-old woman, and has done her homework because she's being offered a double mastectomy, and she doesn't want to go down that route. She wants to know, is there a way that she can protect her breast tissue and screen herself and just stay on the right side of this gene risk that she's got? And of course, there are ways that you can do that without taking such drastic action. So she came for a thermogram. But one of the things I made a point of telling her was, don't let doctors convince you to have an annual mammogram because of your BRCA. Because that's what the science shows. And it will just increase her risk of running into trouble. And yet you'd have thought that doctors should be on the same platform. All groups should be speaking from the same song sheet on this, but they're not. What do we know generally? And this is just a summary statement of all the work with mammography. For every 2,000 women screened over a 10-year period with mammograms, 1 life would be saved. But 10 healthy women would have unnecessary treatment, i.e. radiotherapy, mastectomy, chemotherapy, for cancers which would not have threatened their life. And at least 200 women would face psychological distress for many months because of false positive results. That is a summary statement of what we know about mammography and what we achieve with mammograms. Now this is well worth you noting down, and actually I don't mind, ladies, if you take a photo of this one, because this is from the Cochrane collaboration site, and it's a 6-page document written by them for women to be able to read, download, print off, to inform themselves on what is the latest evidence regarding mammography. So that if they still choose to have one, at least they're making an informed choice. So I recommend that all women considering a mammogram read this first, and if you still go ahead and do it, fine. You've made that choice on the basis of solid scientific information. Okay, time to talk a little bit about thermography and how it differs and why I believe this can be an extremely useful tool in us changing the game in breast cancer risk. Okay, so what is it, first of all? Well, thermal imaging, or I prefer to call it thermography, mammography, thermography, yes? It uses highly sensitive infrared cameras to detect heat coming from the surface of the body. So we're not looking for structure, we're looking for heat changes. And with the modern digital cameras, we can detect temperature changes down to 0.025 degrees centigrade, so highly sensitive cameras, okay? It's actually been FDA approved since 1982 to be used in conjunction with the existing screening technology. So is it new? No, it's been around for a while. So you might ask the question, well, why isn't it more widely available? We maybe discuss that in the questions at the end. I would argue thermography is much early detection because we're not looking for structure, we're looking for earlier physiological change that is manifest as heat. Okay? And there are two key processes that generate heat in a cancerous breast or where a cancer is developing. One is the higher metabolism of cancer cells generates more heat. And second, the process called angiogenesis, which is bringing or the formation of new blood vessels to nurture the growth of a developing cancer, that new circulation also creates heat. So these changes precede the structural changes that we see on mammography and therefore give us an earlier detection advantage. It is thought that an abnormal thermogram is the single most important marker of high risk for developing breast cancer. Studies have shown 61% increase in survival rate when thermography is combined with mammography. So that's important. It is 10 times more significant than family history. What do I mean by that? Basically, if you have an abnormal thermogram and you continue over time to have an abnormal thermogram, then your risk of developing breast cancer is 10 times higher than if you had a family history of it. Now, bear in mind that a family history is only found in about 8% of women who actually develop breast cancer. I don't know if you knew that. Only 8% of women who develop it have a family history of it. Does it increase your risk if there's a family history? Of course. But that only occurs in 8% of women who develop breast cancer. That means 92%, roughly, of breast cancers are nothing to do with family history. So it means that we must consider the environmental factors that are increasing the risk. And what we do about those is very important. And that's a large part of what I do in my advice to women who come for thermography, even if they have a normal scan. Advise them on how they can lower their risk over time. And there are some key things they can do. It's 100% safe, no radiation at all. You can use it even if you're pregnant because there's no radiation. For women with implants, you can still see thermal changes around the implants, or whether a woman has dense or sensitive breast, doesn't matter because there's no contact, there is no compression. It's like having your picture taken. The only difference is it's an infrared camera, not a normal camera. So it's picking up heat changes. The beauty is that we can use it to screen young women because it does not matter how dense your breast tissue is. We're looking for physiological change, not structural change. So not only does it give us an earlier detection advantage, we can actually start screening younger than 50 years old. See, there's the potential of it. Now, of course, it's important when we're doing a thermogram to consider the medical history. For example, things like, and I won't bore you with this, hormone exposure. Has the woman a history of taking birth control pills, which we know increase risk? Has she taken HRT? Is there a family history? What's the age at first pregnancy? Because the older a woman is at first pregnancy, the greater the risk of breast cancer later on. General points, overweight increases risk. Certain ethnicities have increased risk. Any chest trauma, it's more debatable, but can increase risk. Age at onset of first period, because that's to do with hormone exposure, we think. Prior biopsy surgery. And last but not least, emotional factors. Very difficult one to gauge, but seems to be a feature in a lot of women who actually have breast cancer, that there's some emotional turbulence that has gone on in the past for one reason or another. All right, let me show you now. Let me talk you through thermograms. This is how we used to do it. It's the old-fashioned way. This is what a thermogram looks like, and the red is hot, the yellow is in between, blue is cool, okay? Green is somewhere in between. If you look at this as the scale here. So this is a kind of an old-fashioned thermogram, really. Used to just circle the areas that look hot and compare it to the same area the other side, and the doctor would type a written report. This is how I used to do it about 15 years ago. And some centres and doctors are still doing it this way. But time has moved on and technology has moved on, and I'm going to show you how we do it now. So that's kind of what it looks like. You're detecting heat. Now this shows you one aspect of thermography which should not be omitted. It's called dynamic thermography, which means that you expose the patient, the woman having a thermogram, to a cold challenge. Now, why on earth would you do that? The reason for that is that the blood vessels that supply a growing cancer don't have a normal nerve supply. And normally, if you go into a cold room, what happens to your blood vessels? They constrict. It's an automatic, autonomic reaction to exposure to cold. But because these new blood vessels don't have these same nerves, you can see a resistance to cooling. And I'll show you an example of this. So, this slide shows that, because this woman, ignore this, this was a patch that should have been removed prior to, so it's a technical error. But you see, this is before cold exposure. Cold challenge, look what happens. This stays red. You see that? Doesn't cool. Look at the vascular patterning here. This was an area of a cancer, which would have been missed if we hadn't cooled. So there are some outfits still doing thermography without cooling, and it's incorrect based on science. So that's why it needs to be done properly. So we think that using this cooling, this dynamic thermography, actually increases the sensitivity of thermography to 96.5%, which is very high. Mammography is about 70, 60, 70%. It reduces the false positive rate to 3.5%. Highly significant. So if you're increasing sensitivity, which is reliability of any test, and doing that increases it, why would you not do it? Now, I'm going to introduce you to the system that we currently use, which I'm very proud of, and the reason I'm proud of it is because I developed it. And I developed it based on 15 years of researching different tools for thermographic scanning. And I've used probably 4 or 5 different systems from different countries, and none of them were quite right, if I'm honest with you. But I wanted to bring the best of all of them and the latest science into standardizing a procedure which all doctors could use. Because my greater mission in this is not just for people to come to see me in Harley Street, it's to make this accessible to women everywhere on the planet. Yep. So, and I know that's a very grandiose ambition, but the point is this needs to be done, and you'll see by the end why. So, it's very important to introduce standardized protocols whenever a woman has a thermogram. So every time she has it done, it's done under the same condition, that it's in a cooled room, that there are no drafts, that there's no bright light. And this might seem a little bit obvious, but it's not always the case. That the patient is prepped the same way, so no coffee, if she's a smoker, not to smoke on the day of scanning, okay? No deodorant, no sunbathing on the day before things like that. There's a list of protocol, but you have to standardize this. Camera technology has moved on. We have highly sensitive, sophisticated digital infrared cameras now, which we didn't have 15 years ago. We used to use nitrogen-cooled cameras originally, and I used to have one. But, you know, they should be swept into the ark now, okay? So, this is important. And also, here's another important thing. Why not use a computer to analyze all the temperature data? Why do it by eyeballing it? Why not ask a computer to analyze the breast that you've screened, and therefore nothing is missed? So that's what ThermoCheck does. And this is just to show you, I won't bore you with this, what you should look for is different temperature changes, but also look at the vascular patterns as well. Yeah, so properly done thermography should do both. Now, is it scientifically validated? There are over 1,000, and when I first wrote this was about 5 years ago, so it'll be more. For over 1,000 peer-reviewed studies on breast thermography, exist in medical literature. Some of these studies have followed patients for 12 years. And I just want to show you two of them that are actually not new. They're quite 1980s. But Spitalier and his colleagues screened, 61,000 women over a 10-year period. And they were able to detect 91% of non-palpable cancers. That means cancers that could not be felt. 91% of them were detected with thermography. That's great. They also went on to say that a persistently abnormal breast thermogram represents the highest known risk for the future development of breast cancer. And that's why, irrespective of family history, if you have a thermogram and it's abnormal, and it remains abnormal when you do it a year later, and a year later, it's much more significant than having a family history. You have got a problem in your breast that is persisting. You follow that? That's what they're saying. This is another study which I like, and 58,000 women screened with thermography. And what they did is they picked out about 1,500 patients with initially healthy breasts but abnormal thermograms, and they followed them over the years. And what this study showed was that of this group, women who had clinically normal breasts but abnormal thermograms, of that group, 40% of them developed breast cancer over 5 years. So again, reiterating this point that an abnormal thermogram means you're a woman at risk, especially if it remains abnormal. Generally, if you look across the studies, and I need to expand on this slide now, but between 1965 to 2003, this is the number of patients averaged between those, quite large numbers. The average sensitivity of thermograms, meaning if you have a problem, the test reliably picks it up. That's sensitivity. It's true positive, okay, is around 90%. And as you've just seen, if you incorporate cooling, it increases the sensitivity even further. Now, what about specificity? Now, what does that mean? Because you hear these terms, doctors using them and scientists using them. What's the difference? Specificity just means true negative. So sensitivity is true positive. So how reliable is the test when it says, or how sensitive is the test means, how reliable is it detecting that you truly have a problem? Whereas specificity, it is if you say a woman has a normal scan, how reliable are you, can you be, or that is a true negative? You see, that's the difference, true negative. And it's about the same, 90, 91 on average, 91. That's incredible. Because I showed you earlier on, mammography is about 70%. Now, this is just a more recent study, again showing high sensitivity. So I'm not going to bore you with the detail because I've made my point. And this is this was published 2015. This is a study actually done in India. And what they did is they used detailed thermal pattern analysis. And look at the accuracies they were reporting. Sensitivity of 100%. That's ridiculous. I didn't think that's even possible. But accuracy of 95.7%, positive predicted value 93%, negative predicted value 100%. See, if you do the thermal analyses by computer and properly, you can even increase the sensitivity of this tool even further, which is why, one of the reasons why with ThermoCheck, we let a computer do the analysis. It adds to the reliability of the test. Now, just a few other key points from the studies. There's some studies which say there's a high number of false positives, but I already told you that if you do it right and you standardize the protocols and you incorporate a dynamic thermography with cold challenging, it decreases the incidence of these. And the other point to make is, well, false positive. If you have an abnormal thermogram and then you have a mammogram and the mammogram doesn't show anything, you can see there's a problem with that. Is it that the thermogram is wrong, or is the mammogram just not able to detect something early? So what is a false positive? You've really got to follow women for 10 years to know if it's a false positive, okay? Persistently abnormal thermograms, we know, means high risk. Not everybody thinks thermography is a useful tool, but if you look across the board, that one of the problems with the way it's been done is its standard protocols are not followed. And that's why you see some variation in publication, is because there's no standardized protocol. They're not all using computer analysis either. Limitations, it does not localize a lesion. So if you have a temperature patch somewhere in your brain, it doesn't mean that's where the problem is, because heat comes to the surface, not in a linear path. It's like a patchwork, because the breast is essentially fat, so, which is a great insulator. So heat comes up in between the fat cells, not in a straight line. Okay? So you can't localize a lesion with thermography. Low metabolic or cold tumors may not show. So somewhere between 5 and 10%, you'll miss very slowly developing cold tumors. So thermography is not 100%. But again, it's a lot more sensitive than mammography. Does not detect microcalcifications. Only a mammogram can do that. But it's the detection of calcification that's led to overtreatment, because not all calcification means an aggressive cancer. All right, so let me show you some examples. This is a normal thermogram. Normal to have heat under the breasts. Breasts symmetrically cool, that's normal. A little bit of excess heat around the neck. Can't remember this patient, but that's a little bit abnormal. But breasts are normal. And this is the grayscale showing there are no abnormal vascular patterns. And this is another normal one. Again, symmetry, heat where it should be, not where it shouldn't be. Same on the grayscale. Now I want to show you 3 examples of women with breast cancer, so you see what the thermogram looks like. Here's the first one. Which side is the breast cancer? Her left, yes. You see the obvious difference. Look at the heat being generated here compared to the other side. Look at the vascular patterning that's abnormal there. It's the same picture I showed on the front of my talk. Okay? Let me show you another one. Left side again. She's obviously got structural change, because you see how the nipple is higher here, but I'm showing you an existing breast cancer just so you see what the thermal patterns look like. Look how much heat is being generated on that side by that cancer. And here's another one. This time on the right side. Again, look at the heat. Look at that density of blood vessels nurturing that tumor. So ThermoCheck, let's talk a little bit more about why this is different, and this is the technology we use. We ask a computer to analyze the breast. We just draw these meshes around and then say to the computer, compare left versus right in all those 35 areas, tell us what the temperature differences are, go back and compare the same breast against itself before and after cooling to tell us if there's any resistance to cooling. All done automatically, as quickly as that by the computer. Why should I sit in front of my computer for half an hour eyeballing when I can ask the computer to do that? You know? And it doesn't miss anything. Now, this is another example. I want you to show, this woman also had breast cancer, just to show you the grayscales. Look at the non-cancerous breast versus the cancerous breast. You can see that there are some contour abnormalities, yeah? So it's obvious, but I'm showing you what the vascular patterning looks like in an existing cancer. I'll show you her again in a minute. I'll show you what the thermal patterns look like. So what we do with ThermoCheck is we mark areas that are of clinical concern. What that means is if a woman comes in and she says, well, I've got a lump here, we mark it on the grid where she's got the lump. That tells the computer, this area, lower the temperature thresholds that you will accept. So it's another level of thermal scrutiny in an area that is of concern. And if it's still negative, obviously it gives us more confidence, you see? So that's built into the system. Now this is how the heat and cooling maps look on a thermogram. It's so that a doctor doing this instantly can see where the temperature is emerging in the breast. So hot is red, moderate heat is yellow. Does it cool? If it goes green and doesn't stay the same color, it means there's cooling. So instantly the doctor has maps that he can look at and say, okay, I can see exactly what's going on here. Now this is the same woman I just showed you with that has a cancer, abnormal. These are the heat patterns. What do you see? You see the significant heat here, moderate heat in yellow. Does it cool? Well, these areas do, but some of them don't. So here's an example of a woman with breast cancer showing thermal changes, vascular changes, and resistance to cooling. Is thermography a good screening tool? Well, let's revisit our 3 criteria. Highly sensitive for small cancers? Yes, because we're not looking for structure. We're looking for physiological change. Cost effective? Yes. Costs a doctor £15,000 to buy a system. And you don't need a lead-lined room because there's no X-rays. You just need to have a cooled room. Very cost effective. Is it safe and acceptable to a population being screened? Absolutely safe. You can use it irrespective of whether your breasts are dense or whether you're even pregnant, it's safe to use. We don't advise it to be used in pregnancy because the breasts become very vascular. But it could be, it wouldn't cause any harm. So I would argue thermography does stand up to scrutiny on all 3 of the points that we said a good screening tool should have. Now this is what the report looks like, and I know you can't see it very well, but it's detailed. What we show is the patient's name, we show them the views, we show them the hot and cooling maps. All the temperature data that the computer has measured, all 35 areas, are logged and recorded on our system and given to the patient in the report by the doctor. So, very detailed report, generated in a fraction of a second by the computer. Literally, as soon as I sign off the vascular patterns, which takes me like 1 minute of my time, it bounces off the cloud, wherever you are in the world, and then comes back into a report within 5 seconds. So it's quick, and it saves doctors time. No longer do I have to spend half an hour generating a manual report, and some centres are still doing it that way. All right, last bit of the talk, last 5 minutes. I want to talk about this because when we talk about BRCA, we talk about genetic risk, family history, etc. What we must consider is that genes are not written in stone. Genes are absolutely affected by the environment in which they're in. So bad genes plus good environment, no gene expression. Bad genes, bad environment, gene expression. Now, modern medicine has not caught up with this and doesn't preach it. It's like they're still advising women, have your breast removed, there's nothing else you can do, you can't manipulate that genetic risk in any way. Incorrect. Science does not agree with that view. There are things you can do. So, and this science is called nutrigenetics, nutrigenomics. It's the field I'm interested in, which is how you change gene expression by non-invasive ways with key nutrients, not drugs. Now, one of the ways I came to this is I developed this thing called Breast NutriCheck, which is a home kit test that women can do anywhere in the world. It's based on just pricking the finger to measure vitamin D, and then 2 urine samples to measure iodine in the urine and also how she's metabolizing her estrogens. So those 3 things are analyzed in the Breast NutriCheck. And we have a mini NutriCheck for those who want to save on cost, which just measures vitamin D and iodine. Now, there's a reason why I'm mentioning these 3 things, because let's take estrogen metabolism for a minute. This just shows you how a woman metabolizes estrogen. And there are 2 main pathways to consider. This happens in all women. Safe estrogens here. Toxic estrogens here. All women produce a proportion of both. But if a woman is producing toxic estrogens mainly, and you can measure this in urine, would you put that woman on HRT? Would you? Well, why isn't this test done routinely to determine if a woman is suitable for HRT or whether you're going to put her at increased risk? Because those toxic estrogens are more likely to damage her breast and uterus. Now, there's good news in this, ladies, particularly. Men as well, actually, because this is also relevant to prostate, protecting prostate. If you eat more cruciferous vegetables, even if you're a toxic estrogen producer, you will switch that woman to producing safer, non-toxic estrogens. And that, ladies and gentlemen, is an example of how certain nutrients change gene expression. Because it's gene expression that determines the enzymes that break these down. And here's an example of how certain plant nutrients can influence the way your genes express so you produce non-toxic estrogens, which is why I do this test as part of the breast NutriCheck panel. It's important to know. Now, this just shows you, if we take 16-hydroxyestrogen, which is one of the toxic estrogens, here you see the normal tissue around the breast cancer. So what do you see? You see staining for toxic estrogen in the cancer tissue, but not in the surrounding normal tissue. Now, we're not saying that the toxic estrogens cause breast cancer, but the point is you see staining for toxic estrogens in the cancer tissue, not in the normal tissue. So there is an association which needs to be considered and addressed. Would you agree? Yeah, absolutely. So, long story short now, to finish this off. Over the years of doing this, I realized there was going to be a challenge. And the challenge is this. The challenge is you have a woman with an abnormal thermogram who you then send, let's say she's a 5 rating, which is how we do a 1 to 5 scale rating. 4 and 5 would be lots of temperature changes or vascular changes, high risk. But you send her for a structural scan, ultrasound, MRI, or mammogram even, and they come back negative. What are you going to do? Because the thermogram is saying increased risk, and the structural scan is saying it's normal. Point to make. Normal structural scan does not mean you have healthy breasts. It just means there's nothing big enough to do. It doesn't mean you have healthy breasts at all. It just means you don't have a structural lesion that's been seen on that scan. And here is another important difference between mammography, MRI, ultrasound versus thermography. Those are detecting a problem. Thermography is detecting a stressed breast, which may not necessarily be cancerous, but could lead to one if left unchecked. Do you see the difference? And it's exciting because it's one of the things that gives us an opportunity to change that woman's risk. So over the course of the last years, based on doing lots of NutriChecks, I've developed a couple of supplements that I use routinely in my practice that give these breast health nutrients back to women. And now I want to show you 3 examples of women who have had abnormal thermograms, have been exposed to breast health nutrition. What happens? So here's the first one. She's got a 4 rating on her right breast, and I'm not showing you the other breast because it was normal. Hot nipple, and this area is hot. Does it cool? Yes. It does cool in this scenario. But here she is in December 2015, and here 9 months later. That's her breast. High risk, low risk. Just changing the nutrient levels. Here's another one. 53-year-old woman, no family history. She's a 5 rating on her right breast and normal on her left breast. Again, all cools. Here she is between April and October, 6 months later. High risk, low risk. Here's the last one I want to show you. This woman has got a family history of breast cancer. She's age 60. She has a 4 rating, hot nipple, and this area here gives her 2 extra points. 2 is normal. Again, normal cooling. So we can't always go by whether there's resistance to cooling. But here she is, completely normal in October, again 6 months later. Now, I want to show you, this slide shows you the results of about 80 patients who went through the same protocol, and now this is higher numbers. I just haven't updated the slide yet. But here's how many normalized of that group of 80 patients, 72.4%. How many of them were going back to normal? 10%. That means we've got 82% either normalized or normalizing over 6 months. Only 17.3% unchanged. This is what gets me excited. It's not just thermography. It's that tool, the opportunity that tool gives us to make those changes to that woman and take her from a high risk to a low risk position in as little as 6 months. That is the story. That's the story that everybody should hear. And it's the same story that I'll be presenting to 150 doctors in Antwerp next Saturday. So, summary, no perfect screening tool exists. There is not really. Mammography evidence suggests it has doubtful merit in screening and may lead to overtreatment. Earliest detection is offered by thermography, in my view and my research. It has the potential role in early detection of breast cancer since it's looking at physiological change. Adherence to defined protocols will help maintain consistency and reliability, very important in terms of doctors offering this. The latest technology, ThermoCheck, is a computer-assisted analytics of the images, and it's likely to lead to even greater accuracy and more thorough temperature analysis. It gives the best opportunity to remove a woman from high risk to low risk, altering lifestyle and nutrient levels that have an impact on breast tissue health. And that's what we're doing. That's the work that we're doing at The Natural Doctor. It's the work that I believe needs to get out there, and hopefully after next weekend, we'll have a fair proportion of doctors signing up to take this on and offer it in their own clinics across Europe. That's our mission, it's my mission, and it's what I wanted to share with you this evening. So thank you for coming, thank you for listening. That's all for this evening.